everyone, and thank you for taking the time to attend this webinar. I want to thank all of you who decided to join us today, whether it's the morning, evening, or afternoon, depending on where you are in the world. We have participants from South Africa, the United Kingdom, Egypt, United Arab Emirates, Brazil, and many, many other countries, as well as those here in the United States. So thank you very much. I know each and every one of you are very busy. However, by taking this time, you are showing your commitment to delivering exceptional patient care. My name is Parag Kachalia, and I'm the Vice Chair of Simulation, Technology, and Research at the University of the Pacific Arthur A. Dagoni School of Dentistry in San Francisco. And I maintain a private practice just east of here in San Ramon, California. Today I would like to discuss the new world of adhesive dentistry. Tooth color restorations are being performed in all of our offices today, and the recent advances in adhesive dentistry allow us to perform these procedures in a more predictable manner. Over the course of the next hour or so, we will tackle 3 key objectives. The first will be, I hope to share with you the current state of dental adhesives. Next, I'll show you some clinical cases with respect to new flowable composites and discuss how flowable composite usage can be leveraged in your practice. They're much more than they once used to be. I also hope to provide an overview on self-adhesive resin cements today and how they can be used with the new ceramic materials that many of us are utilizing in our practices, including zirconias and lithium disilica restorations, or EMAX. When we think of placing a resin restoration, the success of the restoration is dependent upon at least 4 key factors. These factors are an adhesive bond that's proper, the characteristics of the resin or composite being used for restoration, having an ideal armamentarium and equipment that we're utilizing, and then proper polymerization, so that the resin restorations we're replacing are being cured to adequate depth. While I wish we had the time to discuss each of these areas, we'll specifically be focusing on the adhesive bond. That in itself is a complicated task. So let's look at adhesion. And we'll go into some details with respect to adhesion. Some of this will be historical, and some of this will be current and going forward. And adhesion is a large concept, and we'll try to get our brains around how is it that we can take a resin and actually stick to natural tooth surfaces, whether it be dentin or enamel. So I'm going to show you this photo, and really the question becomes is, what adhesive do we use? Is there a difference between all the different manufacturers that are out there, all the different systems that are out there, or all the different generations? Adhesives quite often are categorized from a generation standpoint. Well, what you see on your screen here is a highly magnified photo of collagen and some dentinal tubules. In an ideal world, we would have highly fluffy collagen like this in every case. And a tremendous amount of surface area would be available to form a predictable and strong adhesive bond. The difficulty comes to the fact that each adhesive over the years had its own instructions and usage, and the ability to get a fluffy layer of collagen can be difficult. And over time, each generation has had its own specific technique. What I want you to think of in terms of adhesive bonding is, imagine a fresh bowl of pasta you've just made, and you have some fresh noodles. When those noodles are first boiled, they're nice and fluffy. And if we take a spaghetti sauce or sauce of any kind and pour that sauce or tomato sauce over the top of those noodles, the sauce will penetrate into all the different nooks and crannies. And we'll have nice deep penetration, and we'd have a nice bowl of pasta. On the other hand, if you take that bowl of pasta, those fresh noodles, and before you put the sauce on it, put it into the refrigerator, and 24 hours later you pull out that bowl and go to pour spaghetti sauce on it, it will not go anywhere. It will just stay on top. And this is very similar to what happens to dentin when we etch it and over dry it. If etched dentin becomes overly dried, it can collapse. the collagen will collapse, and bonding becomes much, much more difficult, and bond strengths drop drastically. So for years, industry has looked for ways to minimize the chance of collagen collapse, to get that variable out of the way. Or if collagen is to collapse, how can we fluff it back up? And we'll be talking about that. The very first generation we'll look at is what we call fourth generation adhesives. Now, fourth generation adhesives have been around for quite some time. And the reason we start with fourth generation adhesives is these are really the first successful adhesives to both dentin and enamel. Before that, we had success in either category, but it's this fourth generation that really worked with both substrates. So this is the one we'll consider. If we think generally about fourth generation adhesives, they're categorized as a three-step technique. The first step is obviously to etch the tooth structure. This etchant, phosphoric acid, is rinsed away. And that's followed by the application of a primer and then an adhesive. In this generation of adhesives, it was very common to completely dry the dentin after rinsing phosphoric acid, and then re-moistening that collagen with a hydrophilic primer before introducing our adhesive. So we would dry, and then by the introduction of the hydrophilic primer, it would fluff up the collagen. That would then be followed by the adhesive, and the adhesive then penetrated. And this generation of adhesives worked very well, and generally were compatible with both light-cured and dual-cure resins. The only issue with this was there were some film thickness issues because they tend to be relatively thick. In addition, it was a multi-step technique. Common examples in this category include Kerr's Autobahn FL, 3M's Adverse Scotch Bond, and Visco's All Bond Universal, as well as many others that are out there. But here are some of the three more common adhesives you may have seen in the marketplace. So fourth generation adhesives have shown very good long-term performance, and in many ways they're still thought of as kind of the gold standard of adhesives. And Van Meerbeek and colleagues and others showed in a 13-year study 94% retention rate in a randomized clinical trial. So these work very well. And as I mentioned a little while ago, they're compatible with both self and dual-cured composites. Now, as time went on, the industry as well as practitioners were looking for simplicity. So in order to create a more simple adhesive system, the fifth generation of adhesives hit the marketplace. And in this generation, what happened was we still had the etchant, phosphoric acid, as step number one, and the primer and adhesive, which in the past had been separate components, were combined into a single bottle or one component. While in theory this technique provided simplicity, it also introduced some technique sensitivity. As technique sensitivity increased, we also saw an increase in patient sensitivity. The instructions with this generation asked for moist dentin after etching. In prior generations, it was easy to define dry. In the fifth generation of adhesives, the idea of moist dentin came about. And moist dentin can be interpreted differently, and this variable led to sensitivity, as collagen was being collapsed from being overly dried. This in turn led to practitioners having upset patients, so many started to use a desensitizer, such as Gluma or microprime, and that desensitizing step came directly after the etchant. So the tubes would be etched, then dried, and then a primer, for all intents and purposes, via Gluma or microprime was added. In addition, what we also found this generation is that the primer and adhesive combination tended to create too much of a hydrophilic and acidic component. So they led to some incompatibility issues with dual-cure resins. Now, with respect to light-cure resins, fifth generations have worked very well, and many people around the world have had great success with it. When we think of this generation of adhesives, there's a number that are out there, but here's three that you may have seen. We have Ivoclar's Excite, Autobahn Solo Plus, and PQ1 by Ultradent. There's also Primbond NT and 3M's products, etc. in the marketplace. There's many out there that had great success. As sensitivity started to come about with our patient pool, industry as well as practitioners were looking for a solution where the etchant would decrease, where phosphoric acid would no longer play the role it had historically played. As the thought was, a lot of the sensitivity was coming from exposed dental tubules, from over-drying, and from the etching process. If we don't have to go through a true etching cycle, sensitivity in theory should go away completely, or at the minimum, decrease drastically. That really brought around 6th-generation adhesives. In 6th-generation adhesives, these were now known as self-etching. In the past, etching was a separate step, but now what happened was the primer and the etchant, it became an acidic primer as the first bottle. So in 6th-generation adhesives, the first bottle is essentially an acidic primer, and the second bottle is the adhesive itself. And there's no separate phosphoric acid that is utilized. In this generation of adhesives, we tend to see high dentin bond strengths, but generally low enamel bond strengths. In addition, sensitivity issues are minimal to none, and this generation is generally compatible with all resin materials. It does require 2 separate bottles, but they tend to be compatible with all materials. And some of the ones you may have seen out there are Danville Materials Prelude, Autobond XTR, and Ultranet's Peak SE bond. The only drawback in this category really has been enamel bond strengths have not been great, and the enamel etching patterns have been relatively minimal as a general rule of thumb. Now there's some exceptions to this, but as a general rule of thumb, the enamel etching pattern tends not to be what we see with phosphoric acid, but the dentin bond strengths are very, very high. In an ideal world, we would really have an adhesive that combines everything into a single bottle. I guess in an ideal world, we would have a resin that does not need an adhesive at all. But realistically, if everything was in a single bottle, that would be the ideal component because it would allow for simplicity, right? And we would have no phosphoric acid. So manufacturers for a number of years have started to look at this path and see what can be done. And there have been relatively mixed results in this category over time. Dentin bond strengths, once again, tend to be very high. However, enamel bonds still tend to be low. And then today's 7th-generation adhesives can work well if something called a selective etch protocol is utilized. And we'll talk about selective etch a little more in detail. What selective etch does, it allows the enamel pattern to get etched, but does not etch the dentin itself. So if we're going to use a technique like that, we'd also want an adhesive that's forgiving in the event any of the phosphoric acid gets onto dentin. And some of the products in this category are Kerr's Optibond All-in-One, GC's Genial Bond, and Ivocar's Adhese Bond, or Adhese 1. And these are some of the adhesives that you see in the marketplace. Well, when we think of 7th generations, there's obviously benefits and drawbacks, and we'll discuss these. The big benefit is there's generally no dentin sensitivity. We also have very high dentin bond strength and a single bottle application, so we're not managing inventory for multiple bottles. There's a simplicity in that standpoint. The drawbacks, however, are moderate to poor enamel bonds and incompatibility with dual-cure materials in the marketplace. So we tend to use dual-cure materials for core buildups or cementation. We're using a dual-cure resin cement. 7th-generation adhesives historically may not be the best ones to use. Now, with that being said, for traditional resin dentistry, these can work well, especially if we utilize a selective etch protocol. So let's take a look at some of the adhesives that are out there within this category. Now, if we look at the 2-step 6th generation, one of the best ones we've seen in the marketplace is Curari's Clearfill SE Bond. It has a nice enamel etching pattern. The only downside with that product is it tends to be a little thick, and it's actually not indicated for indirect dentistry. Now, on the other end of the spectrum, when we looked at these 7th generations all-in-one systems, our enamel bond strengths were not great at first, but they're starting to get better. And we can even see that evolution in GC's product line itself. From G-Bond, we might get 20 megapascals of shear bond strength to the enamel, and today with Genial Bond, we're seeing upwards of 30 megapascals. Now, With this being said, even though we're seeing improved enamel bond strengths, my personal preference is to still etch the enamel. And in all cases I do, I always etch the enamel because I still believe that's where you get the best bond. Now, when you look at this image on the screen, you'll see two different scenarios here. You'll see a total etch technique that's evident with a lower second bicuspid. In that case, it was primarily enamel with a little bit of dentin exposed. So in this case, everything was etched. Now next door, we have a first molar. And on the lower first molar, we see a clear enamel rim. However, there's an abundance amount of dentin that's evident on the pulpal floor. So in this case, I want to use a selective etching technique where I get to use the benefit of some of the new adhesives to really form a nice bond strength, high bond strengths with the dentin. Now, the reality is when we use a selective etch technique, there is going to be some etchant that gets onto the dentin. So what we need is a bonding agent or adhesive that's forgiving, that doesn't suddenly fail in the event adhesive gets onto the dentin, or sorry, phosphoric acid gets onto the dentin. So what Dental Advisor did is they looked at this study and said, we find that with unground enamel, there's a given bond strength when it's not etched. However, when that same enamel is etched, there seems to be a 25% increase in bond strength. Now, if we were to utilize that technique and the etchant was to get onto dentin, what would happen? And what they found was there was essentially no difference. Okay? So in the study by Dental Advisory, we see a 25% increase evident at 24 hours with etched enamel versus the unetched enamel. There is no detrimental impact to bond strengths with relation to dentin. Now, Professor Van Meerbeek also looked at bond strengths with dentin, and he's probably one of the most published individuals in bond studies today. And what he found was he looked at a few different approaches. He compared self-etching, where no etchant is used at all on enamel or dentin, right? So a true self-etch technique where there's no phosphoric acid being used, only the bonding agent by itself is applied to the dentin and enamel. In a second standpoint, he used an etch and rinse protocol with a gentle, kind of dry bonding technique. In a third aspect, he used an etch and rinse with a wet bonding approach. And in all cases, what he found was that the bond strengths were essentially similar across all those variables. And there was no pre-treatment failures or pre-testing failures that occurred. So what this really tells us is that if we use a selective etch technique, in the event etching gets onto the dentin, we're still safe. We do want to minimize the contact time with etchant onto dentin, but if we can avoid it, if it does get there, it does not cause a detrimental situation. As mentioned earlier, 4th and 6th generation adhesives tend to involve more steps. However, they're compatible with essentially all composites. 5th generation and 7th generation, so 5th generation was a total etching technique where there's an etchant and a single bottle. And then 7th generation is a single bottle itself without any etchant. In both those cases, they require fewer steps. However, they tend to have incompatibility issues with dual cure resins. What happens is 5th generations tend to be too hydrophilic, and 7th generations tend to be too acidic. So when that occurs, we get this phase separation, and many dual cure materials may not stick appropriately. Now, the new world of adhesives that we're entering into is now this new universal adhesive standpoint. And these adhesives are showing promise. It's newest generation. However, it's too early to tell if these will work in the long term. The key to look for is still compatibility. The pH of the adhesives must be above 3 in order to not deactivate the amines in dual cure and self-cure composites. The key with these adhesives is that also you can use them in any protocol you wish, self-etch, total etch, or selective etch. So they have a broad spectrum that's there, and the research is still coming out. In the event you use one of these, in cases you may see a dual cure activator, a dual cure component that is actually sold in addition to the adhesive you're using, and you may want to purchase that if you're looking at using these adhesives with dual cure resins. Now let's talk about flowable composites. Flowable composites are really not what they were many years ago. They're much more today. In this next section of the presentation, we'll look at some of the expanded uses of flowable composites and how they can be utilized in every practice that's out there. As you see on the screen here, you see really 4 different brands, and these are just some of the brands of flowable composite that are in the marketplace. And there's many, many good flowables that are out there, but these are some of the favorites in my opinion. Whether it's Grandioso Flow by Voco, Beauty Fill by Shofu, Estelite by Tokiyama, or GC's Genio Universal Flow. Each has its own benefits. But what I will share with you is the specific qualities I look for depending on my intended usage. I no longer have a practice where I have one flowable that I use. It's a practice that I now use multiple viscosities, shades, etc. because I use flowable for many, many more procedures than I once did. If we look back, traditional flowable composites were really only used in the following manner. They're really primarily used as a liner in an operative type preparation. Say it was a class 2 type preparation, we placed it on the pulpal floor. We may have used it to repair bisacrylic provisionals. So we took a highly engineered product in some ways and used it as a reparative resin with bisacrylic provisionals. Or maybe we were removing an old restoration and there was left a small undercut, so we may have used a flowable composite to block out the axial walls. And with these limited applications, the thought process was that really any flowable composite would work. If we're using it for all these standpoints, anything would work because the flowable material itself was not truly being exposed to our environment. It was always being capped by another resin or only being used from a reparative standpoint. So we didn't put very much stress on flowables in the past. Today, with the engineering and the research that's gone behind flowables, they can be used for many, many more processes. The properties of today's flowables are very different, and these properties rival those of traditional hybrid composites. Today's flowables are easy to polish, they have high gloss retention, high flexural strength, and great wear resistance. In addition, many of today's flowables tend to be thixotrophic. And what I mean by that is they can flow under pressure or be stackable. So they respond to the way in which we manipulate them. If you simply express it out of the syringe, materials have the ability to stack upon itself. At the same time, if you manipulate that material with an instrument like an explorer or a probe, it tends to have more flow. So that's what we term thixotrophic, when that pressure is applied or manipulation is applied. So in my practice today, I use flowable composites in class 1, 2, 3, and 5 preparations. So in those classifications, 1, 2, 3, and 5, I use flowable composite in all those aspects. Now for each of them, though, I look for slightly different properties. For a restoration that's going to take high occlusal load, so in a pit or fissure or central groove that's a loaded area, I look for high flexural strength. When I use it as a liner, I really want more high radiopacity, and I want a material that tends to flow and gets into the nooks and crannies a little easier. So we take our average class 2 box form. We put a sectional matrice in place, we may use a ring system, and before we put our hybrid composite or nanohybrid composite in, after I've applied my adhesive, I like to take a flowable, bring that into the box form, and bring it up the matrix band and cover the pulpal floor at about 1/2 millimeter in depth. What this does for me is it makes sure that I have nice marginal seal, blocks out any areas where there could be little pits or crevices in the restorative preparation form. And then I go ahead and restore. So in this case, I generally want high radiopacity, being that I take that restored material to the cable surface. And I want it to be easily discernible. I also like for materials, in some cases, right, so in class 2s, to have some color or opacity. So if I'm taking out an old resin or old alloy, for example, and there's some grayness, I want the ability to block out that grayness with my flowable, so that does not look gray to the surface of the restoration. In class 5 cases, I really want the material to be able to stack upon itself. But I also want it to have high wear resistance. So I want it to be able to withstand abrasion from toothpaste, from mechanical standpoints. I want it to be able to withstand potentially erosive attacks that are occurring. So when we take a look at these materials, the flexural strength is pretty phenomenal. In flexural strength, the materials today, and if we take GC's universal flow, is amazingly high. And it's similar to or higher than conventional composites. Filtech Supreme is probably one of the most popular composites in the world today, and it has a flexural strength in the 160 plus megapascal range, and we have flowable composites today that are approaching that same flexural strength. Now the ISO standard is 80 megapascal. So the ISO standard for restorative case in which a load is going to be placed onto the resin, we look for 80 megapascals as a minimum threshold, right? And the goal is to beat that number as a minimum threshold. Now thankfully, the materials in the market today really far exceed this number. So that's part of why we're becoming more and more comfortable using flowable composites, even in areas that may have some occlusal load, as long as they're kept relatively small. Okay. Now when we think about flowability is very different. Today there's multiple viscosities that are available, and in many cases we can have one viscosity that acts differently depending on the amount of pressure that's indicated. So as we discussed previously, in a class 2 box form, I want things to flow into all the nooks and crannies as well as across my pulpal floor. But at the same time, I want sculptability in a class 5 type scenario. The new age of flowable materials, that are utilized day after day in practice, I really utilize them for kind of minimally invasive preparations. We all know there's nothing better than natural tooth structure. Manufacturers have done a tremendous job trying to create new products and materials that are out there, but there's still really nothing better than natural tooth structure. So we want to do everything to maintain as much of this natural tooth structure as possible and not make preparations larger than they really need to be. And that's what I think of as conservative occlusal restorations today. If we enter surgical treatment, as we just discussed, I want to keep that preparation as small as possible. And part of that is looking at the armamentarium and looking at burrs that are available with very narrow tip designs, but also a narrow neck design to allow proper visualization. We don't want to open up preparations just to be able to see past the burr. We want to keep things as small as possible. We must be cognizant that when we embark upon conservative dentistry, we must have the right armamentarium. These burrs allow conservative and detailed form to occur. In another example, in this slide here, you see a comparison of a conventional burr and then burrs that are much more precise today. The last thing we want to do is go through the process of diagnosing a caries area early and then open the restoration to be much larger than it needs to be, simply because all we have in our burr setup is a 330 or 557 burr. The simple question I always ask is, if this is my child, what type of burr would I want to use? What type of preparation would I want to do? Being that there's nothing better than natural tooth, I want to take as little tooth structure away as possible. So the one on the right-hand side of the screen you'll see is a fissurotomy type burr. And the diagram of the images that are shown here is to say the depth you have to go to in order to get anywhere close to what the initial penetration may have been with a 557 burr. Okay. Now, in addition to burrs, we also need to think about having small microbrushes and condensers in our office if we are using conservative restorative techniques. And the reason we want to do that is because we want to make sure we apply adhesive all the way to the base of preparation. The instruments you see on the lower right-hand side are by American Eagle, and there's many companies that make very small, detailed microbrushes. If we do not use these small instruments, what tends to happen is once we have etched the surface, we're using a traditional etching technique, bonding agent actually does not get to the base of the preparation, and a small gap occurs. And when that small gap occurs, these are those common instances where you have a patient where you did a very, very small restoration and they come back with sensitivity. The reason they come back with sensitivity, one of the reasons is there's actually a little micro gap that forms between the dentin and then the restorative interface. And in that micro gap is hydraulic flow that's happening. So every time they bite down, there's a hydraulic flow that occurs, and that hydraulic flow leads to that sensation of pain that occurs. So in addition to small burrs, I also advocate small micro brushes so that we can get that adhesive right down to the proper pulpal interface. Now, we also want to be able to get nice control of our field. So control of the oral field is incredibly important. So I personally do 100% of all my dentistry underneath a rubber dam or an isolation type device like the iSolite that's pictured here. This device allows both buccal and lingual isolation while suctioning away saliva and keeping a dry field. A secondary benefit of this is it allows you to work in multiple quadrants, so you can work on the upper and lower quadrants simultaneously. Some of the research that is coming out is showing that an iSolite is just as effective in terms of moisture control and decreasing humidity as a rubber dam. It's much easier to place in many instances. It illuminates the field if you choose a light option. But most importantly, things stay dry. And when things stay dry, resin dentistry becomes more predictable. So in addition to microprep burrs and the brushes, I also like to use air abrasion and keep things very conservative. The vast majority of the time I do these minimally invasive restorations, I do them without any kind of anesthesia. As a fine surface of the burr removes tooth structure, yet patients rarely report any kind of unbearable sensitivity. We all know patients are much happier when they do not need to become numb. So if we're able to do conservative dentistry with small instruments, they tend not to feel it. We can restore the patient to completion, and that leaves a happier patient. And I truly believe that a happier patient that does not need to go through unnecessary anesthetic ultimately leads to more patient referrals for our practices. So here's an example of a microprep and then the restorative aspect. The patient presented with decay of the upper first bicuspid. Okay? This is evident both visually and utilizing a fluorescence-based imaging device. So upon visual inspection, the upper left first and second bicuspid look very similar. They both look like they have a stained groove. But underneath fluorescence imaging, what we found was that the second bicuspid was purely stained, and the first bicuspid actually had carious activity. So the decision was made to conservatively open up and remove the pathology that's there. So after the caries was excavated and removed with a fine instrument, a standard total etching protocol was utilized, being that there was an abundance of enamel. Once that was done, the adhesive was applied, it was cured, and then the genial universal flow was used to restore. And that's what you see on the far right-hand side of the screen is that restored restoration. This was done in a matter of minutes in the hygiene operatory, because we had the setup in there as well, and the patient was on their way without any kind of anesthesia. In a similar case, caries is evident on the lower second bicuspid. So we see distal pit caries here and some early mesial pit caries. Once again, a Fisher Army burr was used to remove the decay. The entire prep form and surrounding enamel was etched. Adhesive was applied, and that was cured. So we see the total etch technique here after the preparation. We then have the adhesive applied, fully cured, and that's where you see that glistening that's coming from the tube. And then I utilize this special tip that comes with the genial universal flow that allows the adhesive to be put in place. Allows the resin to be put in place, excuse me. And when we put that resin in place, we have to be cognizant of the fact that this resin needs to be cured in increments of 2 millimeters or less. Right? So there's many bulk fill composites that are entering the marketplace today. A genial universal flow is not a bulk fill composite. There's many indications for this material, but it is not a bulk fill. So I'm always using this in 2 millimeters or less, and then I manipulate the resin with a standard explorer. By manipulating this resin, I take a relatively highly filled material and allow it to flow across my pupil floor and then get to full anatomical form. Once that's done, we go ahead and cure it. And what you see in the final photo to the far right-hand side of the screen is that essentially it seamlessly blends into the adjacent surrounding enamel. It's a nice blend that occurs. We get just a little warmth from the dentin below and then blends nicely into the adjacent enamel. And this is all done underneath an isolite type situation in this case. So if you look at the middle photo, directly behind the syringe tip, you'll see a little hole through some plastic. That's the vent on the isolite, and that's what's put in place when this is done. Now, the other standpoint is, in addition to performing conservative class 1 restorations, I really like to use flowable composites for treating class 5 carious and non-carious cervical lesions. In this case, this patient has very good hygiene. There's not a speck of plaque or tartar on any aspect that we see in this patient. She has very, very good hygiene. However, her tissue is a bit thin, and over time, her tissue is receded. Being that she's an aggressive brusher and uses a relatively high abrasive toothpaste in the past, we recently changed her over. What's happened is over time, her root surface of her teeth have continued to wear and then have broken down as the tissue is pulled back. So as the tissue is pulled back, the cementum got exposed. As the cementum has got exposed, we start to see this notching standpoint that's there. Some may refer to these as fractions. Others may refer to these as non-carious cervical lesions. Regardless of what we want to call them, they're areas that are caries-free and they're notched areas of tooth structure. Now to combat this, to kind of combat the issue that's there, ideally what we need to have is a nice restoration that's placed that seals and has a nice long-term wear characteristics that are in its favor. We hope to change our habits, obviously, but at the same time, we want to be able to prevent further breakdown in the future. Now, if we take a closer look, in this close-up view, the cervical standpoint, you see that abrasion issue that's evident, right? And she really has an aesthetic concern at this point. She likes to have teeth that do not have this kind of brownish notching that's occurred over time. And at the same time, she's had a number of crowns and veneers and things done over her lifetime, and she would prefer to not have any kind of indirect restoration that's done. At this point in her life, she's 90 years old, and at this point in her life, she really wants to have a conserved restoration that's placed that looks nice, where she doesn't feel like the brownish area is evident. So I'm going to take you through the process of how we restored this case, and why we looked at these new flowables today, and looking at flowables that do not wear very aggressively. So when we think of wear resistance, a lower wear rate is better, right? So sometimes high numbers are good. In this case, a low number is good. We want a low wear rate. Traditional flowable composites essentially would break down very quickly. They did not have the ability to withstand wear in the past. However, today's materials exist that rival traditional universal composites. You can see in this graph here, products like Renamo or Genial Universal Flow rival that of Filtek Supreme Ultra. So Filtek Supreme Ultra here is a universal composite, has always had great wear characteristics, and today we're approaching that with some of our flowable materials in the marketplace. So let me take you through this process. So what you see on the left-hand side of the screen is obviously the pre-op. The right-hand side of the screen is after we place direct resin restoration, so direct flowable restorations were placed. So in this patient's case, we used 2 different shades of flowable composite, 2 different opacities, and we would achieve a very nice natural look without getting aggressive. So what is my setup? What is my armamentarium to accomplish this? Well, generally speaking, if I'm using a material that is thixotrophic, so again, one that moves differently under different types of pressure, I only need 1 viscosity. If you're using a flowable brand that does not have that thixotropic phenomenon, you may need multiple viscosities. The same end result can be achieved. Many times I also need multiple shades. So multiple shades are indicated from a layering standpoint, but generally we're looking at 1 to 2 shades for a given tooth. We're not looking at 5 different shades. I like to use a contoured mylar strip, and the 2 I prefer are something called the Margin Perfect Matrix and the contour strip, which we'll talk about in more detail. Are the 2 I prefer. And as we discussed before, I prefer etching any area where there's enamel. And on the enamel, I place a scallop bevel, so a non-symmetrical bevel followed by an etching pattern. That's what I do on the enamel. I then use an LED curing light to achieve proper polymerization, and silicone cups and points to achieve my polish, in addition to multi-fluted carbide burrs in the event we need to do some contouring. So in the case here, in this photographic series, the very first thing you see is I simply try in the composite. I don't etch anything, I don't bond anything, I simply try the composite in the shade I'm considering, and I light cure. Nearly all composites look different after being light cured, so I never trust an uncured composite. So this really, to me, is a must statement. Is let me cure the resin first, let me get a sense of what it looks like before I move on. Okay. If I decide to use multiple shades or opacities, I do a mock-up. I place those multiple shades in, layer them in the thicknesses that I hope to layer afterwards, right? And then once I'm happy with the coloration, I simply pop them out. So in this case, if we look at the two teeth here, I tried two different shade scenarios in, and the canine matched much nicer, and so that's the shade that we went with going forward. Yeah. I pop that composite out. Again, this is happening under an isolite. I then take a contour strip, which is that mylar strip that you see here, and I place that into the tissue. And once I place it into the tissue, it creates a nice gingival dam or gingival seal for me. So I don't get crevicular fluid leaking, I don't have tissue overlap onto the margin. And I'll show this in a little bit more detail shortly. Now, there are multiple ways, as we all know, to isolate class 5 type situations, right, in which to create a marginal seal. However, in my opinion, the contour strip really works for me. Core does a nice job in terms of retraction. However, the tissue can tend to get irritated, and the resin can get incorporated into the cord, so that the post-treatment aspect and finishing can become difficult. Amalgam Toffenmeyer type bands can work well as they go into the sulcus and create a dam as well. But in this case, it's really difficult to visualize your preparation as the metal band, the opaque aspect, gets in the way. So these are some of the reasons I prefer a clear matrix type system. So here are the two that I like to use. Now, traditionally I use Ivoclar's contour strip. However, at least in the United States, this product's been discontinued and it is no longer being sold. So the product I use now is something called the Margin Perfect Matrix. And this is by a small little company that Paul Belvedere, as many of you may know, Dr. Paul Belvedere and Doug Lambert, have in Minnesota. It's a very similar concept. It's just a little thinner version compared to what the contour strip by Ivoclar was. So it's easier to get in place. So here's a close-up standpoint on another case. In this case, it's a canine. I take that contour strip once the preparation is complete. In this case, the preparation needs to be done as caries is being removed. We take that contour strip and push it into the tissue. Okay. While that's done, once that's done, I take a small bead of any kind of adhesive, and I take that small bead of adhesive on the outside of that contour strip, place it on the tissue, and essentially form a seal between the tissue and the contour strip. Once this is done, I then go ahead and cure it, and this gives me that external seal. And then from that point, I go ahead and simply start to restore with my flowable composites or traditional composites in cases that is needed. But that's where the seal is created. So if we go back to the patient we had talked about with the upper canine and lateral, in this photo we've already restored the upper right lateral incisor, and we're now working on the canine. An opaque shade was placed mid-preparation at about a 1 millimeter increment. And the opaque shade I used here was an A opaque 3. Placed it at about a 1 millimeter increment, and then I went ahead and light cured that. The instruments pictured to your right-hand side of your screen are really the instruments that I use in this case, as well as the traditional Explorer to manipulate the resin. Next, I took an A4 shade. I took the A4 shade of standard opacity, and that thickness was about 2 millimeters in thickness. We placed that over the top of the cured opaque composite, went ahead and contoured that appropriately, blended that in to our enamel margin, and then went ahead and cured that. And then once we cured that, we took our matrix, our mylar strip off, finished things back in place. Now, part of the big reason that I like to use different opacities is because it allows me to manipulate color easier. So when choosing a composite, I like to consider this wide range of opacities. Now, I don't have every one of these opacities or colors in my office. I think that may be unrealistic for many of us. But I do have multiple shades, okay, and a couple different opacities. So with respect to class 5 lesions, in most cases it's a combination of an A opaque 2 or A opaque 3 with an A2, an A3.5, or an A4. And I would say 80 to 90% of cases can be accomplished by having those 5 composites. So as you can see here, here's an image of the completed case. So here's a completed case, and I believe we have very reasonable color match results in nice contour. So this allowed me to be I do very nice conservative dentistry with direct resin versus kind of more aggressive indirect dentistry. Now at times, indirect dentistry is the right thing to do. It's the way to get the most predictable restoration. However, other times we can use a direct aspect and attain results that can be quite pleasing to the patient. So in a relatively short amount of time, we were able to have this patient in, and she was able to leave with a result on the same day that she's very happy with overall. So nice end result. Now, the reality is, at times we must do indirect dentistry. That is a reality. And in my practice, we do indirect dentistry all the time. So there's a time for direct, there's a time for indirect. So in the world of indirect dentistry, there have been many new materials that have hit the marketplace. And in addition to new materials, there have been new cements that have also come out. So the days where we simply use a zinc phosphate or a glass ionomer type cement are slowly fading away. Those cements can be used still in the right cases, but really resin cements and these new bioactive cements are really starting to take hold with a type of dentistry many of us are doing in our practices today. But let's take a look at some of the statistics. So in the United States here, Glidewell Laboratories is one of the biggest laboratories in the country, and they do millions of restorations. So they've done millions of restorations over time. And if we look at their data in the last year to 2 years, what's very interesting is to see is a drastic change that's occurred. If I put up a chart from 2005, what you would see is a much higher prevalence of porcelain fused to metal type restorations compared to what we see today. In December 2013, if Glidewell takes a look at the work they did in the prior year, really in the post-year, in the anterior we've been all around for quite some time, in the post-year, 14% of all restorations are lithium disilicate or EMAX, nearly 60% were monolithic zirconias, and then we see a smattering of different types of restorations amongst layered zirconias, porcelain fused to metal, and full cast. So the trend is definitely away from metal-based dentistry and towards ceramic dentistry, in particular the usage of EMAX and zirconia. So when we think of cementation, we must consider if we want something to be retrievable. Really, what type of ceramic material are we using is one of the first questions we should ask, right? Is it a full or partial coverage restoration? What is the moisture control like in the area? And this is especially important if we're using a resin cement. We know contamination of resin bond can lead to weakened bond strengths and significant failures. So what we need to do is really sit back and take a look at saying, does the restoration need to be retrievable? Meaning, is it an implant type restoration, an implant crown? Is it a provisional? What type of material is it? Is it a porcelain metal? Is it ceramic? Full or partial coverage? And how is the moisture control? So when I think of provisional cementation, in terms of provisional cementation, I essentially use 2 types in my practice. I use a polycarboxylate type cement for cases where I really want to maintain provisionals for a really long term. Really long term meaning north of 3 months. In all other cases for posterior restorations, I use a zinc oxide eugenol-free cement. In this case, I really want something that's predictable, that does not allow temporaries to come off and emergencies to come about, but they come off more upon command. So when I want to take them off, they come off, but yet they don't fall off, right? In the world of polycarboxylates, they turn to work very well. However, they can be very difficult to clean out the tooth. As my workhorse cement, I like these zinc oxide eugenol-free cements. Okay? And the really important thing for me is that when I take it off, when I take that restoration off, or the provisional off, that the cement goes with the temporary crown. The cement does not stay on the tooth. I want it to be clean. I generally do not get my patients numb on delivery day, so it's more of a hassle than anything else for me to have to scrub the tooth down and cause sensitivity issues. So in an ideal world, I pull the provisional off, and the temporary cement goes with it, and leaves a relatively clean surface where minimal cleaning needs to be done. On the photo to the bottom right-hand side of your screen, you can see how a GC's Temp Advantage is one of my favorites, where I can easily pick off the cement on the initial delivery date of the temporary restoration, and it pulls off in one piece. It cleanly goes away. Now, when we talk about ceramics today, there are a number of ceramics, in my opinion, that truly need to be bonded. Okay, so in these cases, when I think of indirect composites, feldspathic porcelains, all of my Empress restorations, I'm biased towards also bonding my partial coverage Emax restorations, and my very short wall zirconia restorations need to have some additional kind of bonding that occurs. Right. Now, the protocol for full resin bonding is an extensive one, and we don't have quite time for that today. Now, thankfully, we do have many cases where they're straightforward, where they're retentive preparations, and it's a little bit easier standpoint. So when I have a fully retentive, full coverage preparation, I really consider a self-adhesive resin cement. So those are for my full coverage retentive zirconia restorations and my full coverage lithium disilicate restorations. And self-adhesive cements work really well in this category. So here are some of the self-adhesive resin cements that tend to work very well. Technically speaking, self-adhesive cements can work with partial coverage Emax. However, I prefer to use a traditional resin cement with a full bonding protocol that we discussed. So here are some of the ones that are out there in the marketplace, and I'll show you a case or two in just a moment. But let's look at zirconia in a little bit more detail and how I go through my decision-making process. If a prep form has reasonable retention, theoretically, any cement can be used because there's not really a level of expansion that we're concerned where we can impact the zirconia. So in this case, we can use a resin-modified glass ionomer, a product like Fujisem. We can use a self-adhesive resin cement. You can use a bioactive cement that are out there today. You could even use zinc phosphate if you really wanted to. However, many of these full zirconia restorations that we're doing occur on lower second molars that tend to be a little bit shorter and a little over-tapered at times. So in those cases, we actually need to add more retention to the process. So what I like to do in those cases is actually consider zirconia primers. Now, zirconia does not contain any glass. There's no glass in zirconia. Being that there's no glass, we cannot etch zirconia. Okay, so unlike a lithium disilicate or a lucite ceramic, zirconia is not etchable. So being that we cannot etch it, we also cannot use the traditional silane into those aspects. So in that case, what we use is zirconia primer. And all these primers that are listed on the screen here work very well. So a few years ago, Pascal Magnier at a University of Southern California, USC, looked at zirconia primers and said, do they increase bond strength of resin to zirconia or not? And what he found was essentially across the board that there was a definite increase in bond strength between the resin and the zirconia substrate whenever a primer was used. We tend to find a tighter bond. So there's really no downside, in my opinion, from using one. So that's what we tend to do. At the same time, we can utilize things on the dentin substrate if needed. But let's take a traditional case, a traditional nice retention case. So in this case, I did a zirconia-based 4-unit bridge or fixed partial denture, and the vast majority of this restoration was monolithic. So the occlusal table, the lingual aspect, was all 100% zirconia. On the facial standpoint, on the other hand, we went ahead and utilized a veneered zirconia. So we put that essentially into a non-functional area so that in a lateral movement there was no function on the cusp tips. But that veneering ceramic added a nice aesthetic benefit. And what I used here was the GSEM Link Ace. And part of the reason I use this is because I like things that are easily cleansable and also do not negatively impact the aesthetic value of the bridge. While zirconias are opaque, in areas with conserved preparation, the underlying cement can impact the final color. So we went ahead and lowered the restoration. I put it in place, tack cured it for 2 seconds roughly, and you can see how easily the cement pops off. It easily cleans off. Once I clean all the cement off, I then go ahead and do a 20-second cure of all the margins. So in this case, we happen to take a digital impression, is what was done in this case. So it was a digital impression and it had a shade selection component. And you can see towards the bottom left-hand side of your screen how we have the monolithic zirconia on the lingual aspect, okay, and the functional aspect. And the facial aspect, you can see the more translucent veneered zirconia. But we have a relatively nice color match in a patient that has a very, very difficult shade matching phenomenon that needs to occur. Now, with respect to Emax, because it has glass, optimal adhesion is going to occur when the restoration is etched and silent is placed. So when we etch Emax, we use a hydrofluoric acid, and we acid etch with a 5% solution for 20 seconds. Keep in mind, Emax should only be etched for that amount of time. I would not recommend a stronger concentration of hydrofluoric acid, as it can denature the ceramic that's there. We rinse it with water, apply a silane, load the restoration, and then place that onto a nice clean tooth surface. Get a quick cure, clean away the excess, and then do our full cure. So in addition to just simply placing restorations, we've talked about adhesive bonds and conservative direct dentistry, and then some indirect dentistry and a brief cementation protocol. What we also need to think about is kind of long-term maintenance. So part of my promise to our patients is that I will do, as I'm sure many of you say, we'll do everything we can to make sure their dental health is where it needs to be, but that they also need to do their own part. And for years, we've always disclosed children and shown children where they're leaving plaque in different areas. But in many cases, our adults are actually much worse. So one thing I like to use is GC's Tri-Plaque ID gel. And when we paint that on, what it'll show us is that areas of new versus old plaque accumulation. And this helps resonate with our patients. When they simply say that they forgot to brush after lunch, we can also look a little more closely and say, well, there may be some other issues that are there. And, if we just delivered a recent restoration, the patients, and that restoration was done because of recurrent decay, we can start to educate the patients when they come in for the hygiene checks that they may be trapping plaque by not involving their own home care. And if they don't want to have to go through a similar therapy from a cost and time standpoint, they may want to focus on better brushing habits. And this ID gel really helps show them that in a coloration standpoint. Additionally, we have a lot of acidic beverages and things that are entering our diets today. So I want to try to provide a really more alkaline environment, get the acids out of the way. And then we also want to do the best we can to help remineralize tooth structure. So things like MIPase or 5,000 parts per million fluoride components, xylitol, etc., all help in the remineralization process. So the take-home message really is here, adhesive dentistry can have very predictable outcomes when today's materials are used appropriately and maintenance protocols implemented to create a more favorable intraoral environment. I realize there's a lot of material that was covered in a very short period of time today, but I really want to thank you for your attention.